Great. So we are going to continue with a talk, a policy talk that puts together some of these causal inference methods we have discussed in the context of how they can be used in practice to transform a health system. And I'm very honored to introduce Dr. Rachel Ramoni, who is the director of the Kaiser Permanente in Northern California Institute of Research, and is also an old friend who got her PhD here at the School of Public Health. She was, before her current position, she was, I'm going to say this right, she was the Chief Research and Development Officer for the U.S. Department of Federal Affairs. So essentially, she was in charge of research at the VA, and we witnessed how their led a system-wide transformation to strengthen the connection between research and healthcare operations within the 100 VA medical centers. And anyone who has worked with Rachel in the past knows that she brings a deep commitment to making sure that research translates into better outcomes for the people data are being used to create research. So that is why she's our ideal speaker for this talk, and I'm very glad that she could make the time to speak. So thank you, Rachel.
Well, thank you. It is super nice to be in here. This is the first time I've been in this part of this room because, for many years I was in that part taking all of my basic classes. And I'll start by saying that I did very badly in my causal inference class where Miguel was my TA at the time. But it left an impression on me that endured. And I hope that it will become clear why I became interested in ensuring that VA had a robust causal inference body of knowledge and set of expertise, which is the question that my colleague Ramoni, who is at Kaiser and a devotee and expert in causal inference, he asked me as we went to lunch, he said, "You did badly in causal inference class, yet you were inspired to fund what became VA causal. Why is that?" And I hope this talk will be a response to that. So I'm like really into learning healthcare systems, not in the way that people throw that term out, like, oh, I'm part of a learning healthcare system. I'm like, oh, are you? Tell me more. I really believe in more of the engineering and systems approach to it. And so I was really inspired by, I reached out to Chuck Friedman, who's like the champion for learning healthcare systems, about 4 years ago. And I said, yeah, everybody talks about them in the abstract, but what components do they have? Like, how can I build one? Back then I was in VA. And there are some, pretty straightforward components, and I'm grateful to this group for having published this. You told me there was a pointer here, but I think I'm going to probably mess it up. Oh yes, here it is. This group, Landon et al. I need to call them and or send them a thank you note or something. So publishing is not equal to being a learning healthcare system. We have to engage with the system, and my colleague Nate up there, who is at VA, we said, so many papers are published. You look at how many times they're cited, and you can understand this. In order to really change healthcare, because I'm sure most people go into this line of work because you want to either advance methods that will ultimately help people, or to have your work directly inform the health of actual human beings. So here you can see the various components, and we put some of those into place at VA in a group called the Lung Precision Oncology Program, where you have governance, you have a system of leadership, obviously you have research, but you also simultaneously are doing quality improvement, data and analytics, and importantly, community building, bringing the different communities together. Okay, great. So then I became like a heat-seeking missile for clinical practice guidelines, because especially in cancer, these are highly curated documents run usually by NCCN that really serve as kind of like the sheet music of how should you care for this patient. And they really do link research can inform clinical practice guidelines, which, you know, should then set the standard for quality improvement, which then, you know, ultimately leads to clinical care. And I was talking to Miguel in preparation for this meeting, which really served as a catalyst to my thinking. And you know, he really solidified, yes, clinical practice recommendations are inherently causal in nature, right? You think you're going to give this treatment to your patient, you hope it causes them to get better. And therefore, it became clear to me that there should be greater engagement between the causal inference community and the guidelines groups, and I'm grateful to Barbara for indulging this spiel yesterday that I had with her about how we can do that in a practical sense. So here you can see that really a lot of the clinical guidelines groups don't distinguish between, you know, your workaday observational studies that I was reasonably good at and when I was getting my training, and those that are and are not, you know, they don't distinguish between the causal inference driven studies and your workaday observational studies. And here you can see, you know, the American Heart Association levels of evidence and NCCN guidelines, and you might get well-designed, well-analyzed, but there's nothing here about, you know, target trial emulation or anything of that nature in their levels of evidence, which means they're lumping together very well-conceived causal inference studies with your workaday observational studies. And this, my causal inference friends, is an impediment to you having impact on the world. So here, you know, I come in cheerleading about this, and you know, you can see some of the guidelines groups are a little bit nervous, a lot excited about observational studies. So the American Thoracic Society went out and said, we're going to use observational research to help inform our guidelines. And we made an official statement about it. And, you know, lickety-split, somebody comes in and says, you know, 2 months later in 2021, January and then March, you know, it's not ready for implementation. And, you know, and causal inference not mentioned once in here, right? And then you go, then they come back like, oh yeah, well, you know, there are important evidence gaps that cannot currently be filled by randomized controlled trials. So, you know, we are going to use observational data where it's the best we have. Again, causal inference, not mentioned, not included in the conversation. They apparently haven't gotten the memo about the learning healthcare system and causal inference. So, so I figure that we need to do something about that, and that's really why I'm excited to be here. So we will do the most good for the world if we bridge across communities. And I was talking to Barbara yesterday, and I've been working on a project with Nate to try and bridge clinicians and the guidelines communities with, you know, some of the methodologists. But that link between the methodologists and the guidelines communities really is just not there. And we need to work to build that. And the reality is, there are many more graduates from distinguished schools of public health like this who are like I am. And like, we're great at churning out like the workaday observational studies and saying, we're contributing to the learning health system, et cetera, et cetera. I, as you see, got out of that game and moved into sort of administrative leadership. Those who can't do maybe lead research or something. So, and those who can't teach, lead research. So the literature is flooded with observational studies that are done, you know, with your standard methods. Flooded. So if you are gonna think you're gonna just publish the most rigorous observational studies, that's just not gonna do it. You just put it in there in the ocean of these observational studies and hope that it will stand out as a thing of beauty. So it's gonna be much more efficient if we create more formal connections with our guidelines groups about the importance and the opportunities that are presented through causal inference methods applied to observational data. And here you can see there's Nate right there, also up there, and he was our data VA data person of excellence par excellence, and then here's Channing, who is our subject matter expert in prostate cancer. And we decided we wanted to see, is there a more efficient method to go from observational studies to clinical practice guidelines? And so we got together, and they named it PROFOUND, I forget what it stands for, but we first said, we're gonna form this cross-functional coordinating group that has clinical people on it, like Channing, methodological people on it, including causal inference devotees, and guidelines experts. We have the people who sit on the NCCN prostate cancer guidelines groups in there, because these are public lists of who sits on the guidelines committees, and some of them were, in fact, already VA investigators. And so then we started to make our internal VA groups, guidelines groups, aware of this effort. Hey, we want to contribute to the guidelines. And the key step here was that Nate and Channing led this group of not just one expert in prostate cancer, but we're talking like 6 or 7 people arguing with each other, looking at the guidelines about which node they're going to select to help to inform with real world data. Which one is best poised to be answered with real world evidence? And this project started from just a twinkle in our collective eyes to actually producing a paper that is now being considered by VA for inclusion in the guidelines in under a year and a half. And for something like under $400,000, which as a funder, I was, you know, very happy about. So this, to me, demonstrated that it is possible to efficiently inform clinical practice guidelines at large scale in VA using real-world analysis. And really, this conference is what made me say, OMG, we really need to up the causal inference in these settings. So why I'm here today and why I met with Barbara yesterday was to talk about what are some strategies we can use to better incorporate causal inference approaches to improve this process, and how can we replicate this in other domains beyond prostate cancer. So I want to thank you very much for having me, and I look forward to learning from you both here on the panel and in conversations at the reception.